Hello and welcome back to the FRCS Urol podcast. I'm Sophia Cashman, I'm a registrar in the East of England, and as ever I'm joined by my co-host Hari.
Hello, Hari Rattan, urologist from Nottingham. Good evening, Sophia. How are you?
Good, how are you?
Very good. I can't quite believe we're on episode 4, but there we go.
Yeah, but getting better each time, I think.
Well, I'm not sure we're the best judge of that, Sophia, but no, we've got another guest this evening.
We have, and I'm not sure it needs huge introduction. We're covering the really tricky topic of retroperitoneal fibrosis tonight, so we're really thrilled to introduce Mr. Tim O'Brien to come and give us his expert opinion.
Tim, it's great to have you, and I'm sure everyone knows that you are the immediate past president of BAUS, and how's life post-presidency?
An enjoyable reset, actually. It's amazing how much room there is. I think what I've said to my colleagues, it's amazing how much time you have in your week if you're only doing one job, which is being an NHS consultant, guys, rather than 4 jobs. 60 in January, so a month ago.
Wow.
So post-BAUS, post-60, reset.
Tim established probably the biggest unit in the country dealing with RPF. Was it back in 2012, Tim, you started?
Yeah, no, an interesting patient from Jordan, who I manage privately, actually, really fired my interest in the disease. And I just rebadged a general clinic. I just thought, this is interesting. I'm going to go for this. And it's gone bananas. I think Archie and I have now seen over 600 cases.
Wow.
And we give second opinions on the disease all the time, MDM, clinic, surgery. So we've learnt a lot. We really have. I'm embarrassed by how little we knew at the beginning.
Oh, that's fabulous. So, Tim, we thought we would talk through a case from presentation to diagnosis and management. And I know you're going to share some of your accumulated wisdom with us. So the case that we're going to put to you is of a 55-year-old man who has been admitted under the renal physicians, and he's coming with a creatinine of over 1,000, and he's been anuric for a while. And as ever, the medics have catheterized him, and there wasn't much residual when they put the catheter in. And they've done the usual ultrasound followed by non-contrast CT. And CT appears to show bilateral severe hydronephrosis with some fairly kind of indistinct tissue in the retroperitoneum. And they've obviously had him on the ward, hydrated him, done as much as they can medically, and his renal function's not really shifted. So they've called for a urological opinion. So how do you start off tackling a case like that?
Well, you've got to get the diagnosis right, and obviously you've got to manage the renal failure right, haven't you? So, I mean, the surgical decision comes down to, are we going to stent this patient or are we going to put nephrostomies in? And I'm not sure that's the point of this evening, but, that's often a how sick is the patient type decision, isn't it? I mean, often people get bilateral stents put in, don't they?
Do you find in these cases, in your experience, the stents go in easily, or are they a bit of a struggle?
I mean, that's what the textbooks say, isn't it? And I think, generally speaking, you can get stents in. It depends how severe it is, of course. But yes, I think generally stents will go in. I mean, much more easily than they would in a case of rectal cancer or, the other horrible pelvic cancers where stents are usually the wrong thing to do, aren't they?
So I think you don't have a strong feeling really, as long as they're disobstructed.
I think. Not particularly about what you do. I think the error we see and the error we've made is stents going in and then assuming that the obstruction has been relieved. I think that's the biggest mistake to make is, we put stents in, therefore it's fine. I think you put stents in and you have to have evidence that you've relieved the obstruction, either complete resolution of, the biochemical renal failure or changes in the anatomy of the kidney, has it decompressed. And if there's any doubt at all, then I think you have to put nephrostomies in because, the placement of a stent is not prima facie evidence of relief of obstruction. It's the placement of a stent, isn't it? And I think you have to see as much relief of obstruction as you really would expect to see to be sure that your stents have done the right thing. And I think that's a mistake we have made, and we see all the time. Stents have gone in and kidney continues to deteriorate. So I think that's a little checkpoint in the management. And then I think the diagnostic stuff, I mean, clearly one has to be sure there aren't stones and all those things, but you've got, pelvic tumours. I think for most patients at the beginning, the issue is about, could this be cancer? The main differential diagnosis of retroperitoneal fibrosis is cancer. So if in the retroperitoneum, the genuine retroperitoneum, that would normally be an issue around lymphoma or lymph nodes. And in the pelvis, where RPF, idiopathic RPF anyway, is more uncommon, it's the pelvic malignancies. But this man is in a classic demographic, late 50s. RPF is a perivascular disease. We get very suspicious if the changes you're seeing in the retroperitoneum are not really perivascular, connected to the blood vessels. If they're distant from the blood vessels, you're thinking other diseases. And then one of the tips that we taught by radiologists over the years is that lymph nodes tend to lift the aorta off the spine, whereas RPF tends to plaster the aorta down to the spine. So you're looking for, is this aorta being lifted up by lymph nodes? I mean, you've got to look at all the possibilities, haven't you? Germ cell tumor, lymph nodes, etc. I mean, the commonest thing, tumor, of course, to cause diagnostic confusion is lymphoma.
Sure. So from this imaging we've got so far, i.e. the non-contrast CT, there are some features that might be a little bit helpful, but would you go on then to obtain a PET scan in the acute phase?
Well, we do. I think that's one of our contributions, actually, that we've really we've established the place of PET in the workup of these patients for two reasons. One, it really does tell you about whether there is perivascular avidity, and the other is there avidity? So you're looking for the anatomical distribution of the fibrosis to confirm that it's likely RPF, and you're looking for the intensity of the avidity, because that guides how well the patient is probably going to respond to any systemic treatments you use. So I think our working principle is that if it's avid and perivascular, then it's likely RPF, and then we would rarely biopsy that. But if it's avid and non-perivascular, we definitely would biopsy, because malignancy in that situation is really quite common. So we do get PET. The other reason PET's quite useful is it may show you areas of abnormality outside the retroperitoneum. So, I mean, obviously one has to take histories from patients, and, have the IgG4 related disease comes up as a diagnostic possibility, and they will often have disease outside the retroperitoneum. Patients with IgG4 related disease, they may have disease above the renal vessels. They may have a previous history of having had a neck lump removed, chronic pancreatitis. If we see RPF and there's avidity through the pancreas with abnormalities, it's always IgG4 related disease. So, there are some areas of the body that PET will give you a clue on, which points perhaps to IgG4. I mean, how I could list 10 other diagnoses that PET gives you: polymyalgia, all these other things that we've seen, Erdheim-Chester disease. Ever heard of that? So,
oh yes, I've had a patient with that.
Oh well, there you go. Yeah. So I've learnt the names of all sorts of diseases that could mimic RPF, and IgG4 disease, IgG4 related disease, causes Riedell's thyroiditis. So if you're seeing a lot of avidity in the thyroid and you've got RPF, you're probably looking at a case of IgG4 related disease.
You mentioned biopsies. How do you do your biopsies?
Well, I mean, obviously IR is the first port of call. They're often very reluctant to do it, particularly if it's perivascular.
Yeah.
So if you're asking for a biopsy on perivascular tissue, you're probably asking for a biopsy in the wrong circumstances, because they'll say no, and you probably never needed that. But if you're wanting biopsy of tissue that's distant from the blood vessels, then IR. I mean, sometimes you have to get a surgical biopsy. Lap and robo biopsies are not straightforward in this disease. The commonest error we see on that is that people are nervous about where the blood vessels are. So they take quite a superficial biopsy of perhaps the peritoneum, which is normal. and they don't really get down to the blood vessel level because they're worried about hitting the blood vessel. I mean, Archie's working mantra on this is that the PET is generally better than the biopsy in telling you whether it's malignancy or not. We've had a lot of patients who've had negative biopsies, and the PET is just shouting malignancy, and it's always right.
Oh, interesting.
So we had a case recently from the world's most famous cancer hospital. Biopsy is negative. Please manage this patient's RPF. I mean, it was malignant. I mean, it just looked malignant, and in fact, there was some extra tests done on these biopsies, and it was malignant. So, be wary about a negative biopsy. We had a patient referred from the Midlands actually who'd had an open biopsy, which was negative, and that turned out, to be, positive for cancer. It's not an easy biopsy.
But the message I'm getting, Tim, is that in your practice, you feel that biopsy should only really be reserved for those cases where malignancy is strongly suspected, or there's just no clear outcome from the imaging. Is that right?
No, I mean, biopsy is a very, very important part of the workup of these patients. It's understanding where you have to be relentless about the chase for tissue, and understanding the situations where, well, okay, this is RPF.
But do you manage some without taking biopsies?
Yeah. I mean, if it's avid and it's perivascular and it's, I think diagnostics, how I teach diagnostics is it's a pattern, it's a jigsaw. You don't always need 6 pieces of a jigsaw to know what you're looking at. Sometimes 4 pieces of the jigsaw is enough. It's 4 pieces of a London bus, it's a London bus. You don't need the 5th and 6th pieces. I don't think diagnostics is necessarily, I'm not a massive fan of protocol-driven diagnostics. I think I'm a fan of pattern-driven diagnostics. Is everything about this case suggesting RPF? There's an atherosclerotic aorta, a tatty aorta, it's a middle-aged male, it's perivascular, it's avid, it's RPF. Is the aorta lifted up? Does it look unusual? You got to get tissue. Is it below the pelvic brim? Got to get tissue.
Yeah, I was just going to ask about that. So what is the specific relevance of the relation to the pelvic brim? You mentioned that it's unlikely to be RPF below.
I think the context of your case is bilateral ureteric obstruction.
Mm.
And, as the listeners will know, there's a relatively restricted number of diseases that cause bilateral ureteric obstruction. I mean, TCC is very unusual in that situation, isn't it? But actually, the pelvic cancers are not unusual. They're common causes of bilateral ureteric obstruction. It's relevant from the diagnostics because the pelvic cancers are relevant, and it's relevant from the therapeutics because we don't tend to do ureterolysis for bilateral ureteric obstruction below the pelvic brim. The correct management of that is generally reimplant. I know that gynecologists do ureterolysis for endometriosis in those situations, but that is not something we tend to do. If the obstruction is below the level of the pelvic brim, it's rarely RPF, and the correct management of it, if you're going to do surgery, is to reimplant the ureter, not to do ureterolysis.
Okay, so if we move our case on, then we'll say, for argument's sake, the chap's had bilateral nephrostomies in, and his renal function's improving as we'd hope. Yeah. And let's say that his imaging does show features of perivascular fibrosis, and it's avid. So we are fairly confident that this is proper benign. Awful word, isn't it? Benign, but it's certainly not
non-malignant RPF.
Yeah. So I mean, one of the things that comes from traditional teaching is the use of high-dose corticosteroids in this. Yeah. I think it was a Carter paper, wasn't it, from way back in 2002? And actually, I've dug that paper up because I vaguely remember it from my FRCS prep, and they had the grand total of 12 patients in that initial series. But apart from your more recent work, it's probably one of the most heavily cited RPF papers, isn't it? So, I mean, what do you think of corticosteroids, Tim?
Oh, they work. I mean, they work. I think our contribution has been to suggest that they work best in situations where the RPF is avid. I think one needs to understand that retroperitoneal fibrosis is not just fibrosis, it's inflammatory fibrosis. There's an inflammatory element to the tissue and there's a fibrotic element to the tissue. And really whether people respond to steroids or not depends on how much inflammation there is in the tissue. And obviously how much inflammation is in the tissue will affect their ESR and their CRP, etc. So I think steroids work. They can work beautifully. And we use them. We use them in loads of patients. So you get nephrostomies in and start the patient on steroids. I think where people make the mistake with steroids is that they flog people with the steroids at too big a dose for too long. It's a bit like hormone therapy and prostate cancer. If someone's going to respond to, Zoladex, they respond fast. And I think it's the same in steroids and RPF. If they've got steroid responsive RPF, they respond pretty fast. So I think what we've learned in that area is too big a doses are given for too long. If people, we don't start at these 60, 80 milligram doses, generally 20 BD, and we reduce it pretty quickly, actually. I might reduce it by 5 milligrams a fortnight, so that people are getting an induction course, which is lasting about 3 months, 40 milligrams, 35 milligrams, 30, etc. You can do the maths. And you see responses quite quickly in that situation. If they've got an abdomen full of RPF, they might need bigger doses for a bit longer. Look at the scans and see how much, inflammation and tissue you're trying to get rid of. Massive doses for too long is just, and flogging people for years on these high doses just destroys them.
So when do you typically re-image them? Is it usually about 3 months or so?
Or maybe a bit sooner than that. I was looking at a guy on Monday, actually, who'd come in from Essex, and he'd had a vicious relapse of RPF. He was responding so nicely. You could just tell he was responding nicely, that, we were in a position where we could do nephrostograms, clamp the nephrostomy, see whether the urine was going the right way within 6 weeks. So I must say I'm not a huge sort of treat and forget type doctor with this disease. I do tend to treat and review.
And I guess that's one of the benefits of nephrostomies, is that you can just do an antegrade study or clamp them or whatever. It's always a bit more precarious when you're faced with the decision of taking a stent out.
It is. It is. And so the nephrostomy is in that situation. Often patients will have both stents and nephrostomies. And, it's considered, the stents might have been put in and then people feel they need a nephrostomy or whatever. It's a success to get someone to stent dependent from nephrostomy dependent, isn't it? What we find is that it's rare to take someone from nephrostomy dependent to no plastic dependent with steroids. You might get them stent dependent, but you're probably going to need surgery to get them stent free. It's pretty rare, I think, to take a nephrostomy dependent RPF and get them no plastic with steroids. I think it's where the anatomy of the ureter is really important. I think, again, Archie's really good on this. I think if the ureter is an angulated ureter drawn into the fibrosis, steroids don't reposition that ureter. The ureter needs reposition. The ureter is in a natural position and generally being just, pressed on, then in some situations you may get much more relief of obstruction with your medical therapy. But where you've got a ureter that's dragged into a mass of tissue, I think steroids in that situation are useful, but I'm not sure they're going to fully relieve the obstruction.
So for the steroid non-responders, are there any other medical therapies you try?
That's obviously a really good question. I think if they don't respond to steroids, they're unlikely to respond to the other medical therapies. So there are lots of other medical therapies that are used as an alternative to steroids because people don't like steroids. I think the trial that needs to be done in this disease is a trial of steroid induction versus biological therapy. So the biological therapy that's used in RPF is rituximab, which knocks out your B cells. We use it for recurrent RPF in patients who are particularly keen not to go back on steroids. Probably the trial in primary treatment would be a trial of steroids versus rituximab.
So assuming our chap falls into that category, then, where certainly the imaging shows that the inflammatory load seems to have improved, but he's still being drained and he's keen to get rid of his plastic because he's a young chap and he wants to get on with his life. So tell us about the kind of the planning and timing of the ureterolysis, Tim.
Yeah, I mean, obviously we run a referral practice, so we're tending to see people who've actually been on treatment for quite a while. It's still between 2 and 3 years before most people are referred for ureterolysis. So they'll have been on medical therapy, they'll have had stents, they'll have had some stent changes, and they'll have got bored of stent changes, or they won't enjoy stents, and so all the usual reasons why people end up not liking stents. If it was a patient who was presenting to our department, I think we'd be looking to get a ureterolysis done much sooner than that. Perhaps within the first year, maybe at 6 months, for the reasons you say, that long-term stents and stent changes for a man of 55, that's a lot of stent changes, and I think ureterolysis offers huge advantages over that. Complete relief of obstruction. One of the advantages of ureterolysis, in my eyes, is that if you put the ureter safe, you can be much more imaginative about reducing the dose of the immunosuppression, stopping the immunosuppression, because you're less worried about the consequences of reobstruction or of RPF redeveloping. I think one of the reasons that people are kept on large doses of immunosuppression for long periods of time is that people are worried about re-involvement of the ureter if you stop the steroids or stop the immunosuppression or reduce the dose down to a very low level. Whereas once you put the ureter safe, you can play around with the doses of the drugs much more happily, with less nervousness about the consequences. It's a massive question in RPF. I say Archie and I probably have a conversation about this every single Monday when we do the clinic, is who can you stop the steroids in? Who can you stop the immunosuppression in? I think most physicians keep them going, but patients are really keen to see whether they can be managed without immunosuppression. It's a big question. I mean, I think how do we square that particular circle? I think if people look like they've got an autoimmune process going on, so IgG4 related disease, or a woman with RPF as part of a systemic autoimmune disease, then we would tend to maintain immune suppression. If people look like they've perhaps had what we call slang tatty aorta RPF, where there's an atherosclerotic aorta and then you get RPF around that aorta, I think that's more often a disease that's characterized by a period of time when someone has RPF rather than a risk throughout their life. We don't know what causes a lot of RPF, but okay, I'll give you my thoughts on having seen hundreds of cases. I think some of the patients with tatty aorta RPF, what's happening is that there is fissuring and cracking in the wall of the aorta, and you're getting a release of aortic wall contents into the periaortic tissues. And I think the immune system sees that and goes and lays down sealant around the aorta, probably to prevent leakage. And I think that's what's happening, is the immune system is preventing a calamity, which would be aortic leakage. And that's happening in a stiff, calcified pipe rather than an elastic aorta. Now, that type of RPF, I think, is much more likely to be time limited. You give someone some steroids, they shrink it away, you sort out the vascular system, and maybe they had a moment when they had RPF because it was a response to, an acute event. But in those patients, I think it's quite often not something that necessarily becomes a problem over many years. But it's a really tricky question, who can you stop the steroids in? Who can you stop the MMF in? Who can you stop the this or that in?
And I mean, in terms of doing the surgery, I mean, you and Archie, as you say, have a huge experience over the years now. And I mean, any kind of particular gems you can share with us about the approach to the ureterolysis? For example, do you always try and do a mental wrap?
No, I think that's been one of the sort of open surgical myths that's been debunked by robotics. Do you have to do a mental wrap? In open surgery, if the omentum's there, we would. In robotic surgery, sometimes it's done. I think what's very, very important in the surgery is to get some interposition. I think there's two elements. What I've learned about the operation is there's two elements. Around the aorta, you want lateralization of the ureter, but lateralization over the iliac is meaningless because the ureter has to cross a blood vessel which has got RPF on it. So over the iliac, what you want is interposition. So the tissue interposition has to be over the iliac. At the aortic level, you're talking about lateralization. So two different elements to it. And then I think one of the other big things that we've realized, this may be news to you actually, I don't know, probably, maybe isn't, is how common venous issues are in RPF. So RPF will strangle a soft tube. It will strangle a ureter. It will strangle the cava. It will strangle the iliac veins. It rarely, you don't see arterial obstruction from RPF. RPF arises from disease around the arteries, but they're not obstructed arteries. And it doesn't obstruct our arteries itself, but it will obstruct veins. And obviously, ureterolysis becomes a very challenging operation if someone's got an obstructed cava or obstructed venous. So anybody with RPF who has a history of DVT, they get MR venograms. Anyone with a history of venous eczema, venous claudication. So that's now a real checkpoint in the management of RPF patients, in my mind, is to look at those scans, take a history, examine people for evidence of venous issues, because they're very common. And they can be managed by endovascular techniques. So venous stenting and the like. And obviously, if you're doing a ureterolysis with an obstructed cava, that's there's a lot of collaterals.
Sound like something that you want.
There's a lot of collaterals to deal with. So it's but that's been I mean, I can tell you in 2012 I had absolutely no idea that RPF could produce intense venous obstruction, but I do now. And if we see a DVT in somebody with RPF, they always get imaged because they always have narrowing, and they need management often above and beyond just anticoagulation.
And presumably that needs to be addressed before you go in and do your ureterolysis.
Well, they need an opinion. Yeah, I mean, it's been a happy sort of coincidence that actually we have a huge venous vascular unit in our sister hospital, St. Thomas's, because a lot of vascular surgeons don't do much venous work, really.
Do you find these patients for life? Like, do you ever get to the stage with them where you can kind of make safe their ureters, get them off their immunosuppression and discharge them? Or do you feel like there's someone who needs following up for life?
I think some people do get better, and they have time-limited problems which sort of go quiet and their RPF goes quiet. But then other people it just is relentless. There's just problems all the time. And it's where you can get a slightly false impression of the problems the disease creates, isn't it? Where the patients who have problems dominate your thoughts and your clinics, and the people who have no problems are never in clinic. So you get a slightly sort of biased view about it.
Practically, how do you follow them up, Tim, after the ureterolysis? Do you do a MAG3 or something afterwards?
Yeah, I think we do a lot of renograms, actually, Harry. And just one of the tips on renograms is a lot of people ask us, well, if you're giving people steroids and they've got stents in, how do you know whether, and who can you pull the stents? I think you want to see impressive improvement in the axial CTs. You want to see that there's been some reaction. You want a pretty quiet time from RPF, low markers, no problems. You want to see retrogrades that look encouraging when you take a stent out. It doesn't look like a rat tail. And what we often do is staged removal of stents. So we might pull one, do a renogram, check that drainage is good, see where we are with creatinine. And if we're absolutely happy with it, then we'll pull the other renogram. Yeah. So in a patient who's had a ureterolysis, we'll just pull the stents. But in someone where you're pulling stents after just steroids, we might do it one by one. It's a slightly bizarre aspect of our practice is that obviously because we're both surgeons, we tend to see a lot of RPF that need surgery. Whereas, I'm sure physicians, if they were listening to I'm sure they're not listening to this podcast, but if they were, they'd go, well, we see lots of RPF where steroids unblock the ureters and la da 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 da.
I mean, on that note, Tim, you mentioned physicians. I mean, a lot of these patients do come to us via rheumatologists or renal physicians. I mean, do you have an MDT approach in your unit with the physicians?
We do have an MDT, and it's really useful. I think a lot of time is wasted in MDTs, actually. I'm a bit of a skeptic about MDTs. But actually, in this disease, I think it works. Do we have physicians in that MDT? No. And that is not for want of asking, trying. I think we must have about 2,500 physicians at Guy's and Thomas's, but we need 2,501 to get someone to come to an RPF MDM once a month. Don't get me on that. To be honest, there's a professor of rheumatology, David de Cruz, who does give amazing opinions on people who almost certainly have a widespread systemic immune deficit. And he's very, very good at that and brilliant. And to be honest, I don't want to blow smoke up our own asses. He says, well, you guys know what to do with RPF. He said, you don't need me. That I only need to get involved. Send me the stuff where people have got a polysystem disorder. I mean, it tends to be mostly women, with the autoimmune disorders who you want, guidance on. Obviously, we're not moving these complicated drugs around as surgeons. I don't mind moving some doses of prednisolone around and adding in MMF. We have got a renal physician involved, but again, he's slightly more peripherally involved than. We'd like to have a rheumatologist who got 3 PAs a week to manage these cases. It would improve our service.
In terms of the referral, logistically, would you prefer the PET scans are done outside of your centre, or do you prefer to do them yourselves?
I don't think it particularly matters, actually. I don't think it particularly matters. I mean, I think it's FDG PET that they have, but I don't think it particularly matters.
I mean, Tim, we've covered a huge amount of ground there with this case. I think we've had a really comprehensive discussion about it. So is there anything else you can think of that we might have missed or that you think is particularly relevant?
A couple of tips. Archie talks about no mass RPF, really suspicious for cancer in those situations. RPF generates a mass, and if there's no mass visible, but there's ureteric obstruction, trouble. The lobular carcinomas of the breast, the sheet-like TCC.
I was just going to say, breast cancer is a classic one of those.
Yeah, it is. It is the classic. But there are other things that can do it as well. So be very wary about no mass RPF. There's either intrinsic stricturing of the ureter or there's some other process going on. There needs to be some tissue if it's RPF. Say lymphoma, the diagnostic things, are all about cancer at the beginning. I think make a decision early about ureterolysis. Don't wait for calamity, obstruction, loss of kidney function before making decisions about ureterolysis. Traditional ways of monitoring this disease involve ESR, CRP, etc. And you really need quite a lot of RPF to affect the ESR and the CRP, whereas what PET's very good at is telling you about quite small areas which are highly avid. So you might do a PET scan, and the patient may not have large volumes of RPF, but they may have an intense area of avidity over the iliac, which is a high-risk area. And the other reason that PET's been useful is that obviously loads of things can affect the ESR and CRP, infections, pyelonephritis, all those other things that patients have at presentation. And what the PET's telling you about is what's happening in the retroperitoneum, not what's happening with all the other things that can happen, that can affect the ESR, CRP. So that's where it's been also very, very useful. The biomarker for active RPF that no one knows about, iron. So if you have inflammation in your body, you don't absorb iron. It's the way I can't explain everything on this podcast about it, but basically inflammatory disorders cause iron deficiency anemia because of a failure to absorb iron in the gut. And patients with RPF have low iron, and they need intravenous iron giving to them to restore that. But it's We would be, I have to say, I think we would even be quite suspicious about a diagnosis of RPF if the iron was normal.
Wow.
No idea.
At the beginning.
That's something I've never come across.
Yeah,
Wow.
well, you probably never measured it.
That's
and
definitely
then one thing we haven't cracked, and it's a nightmare, awful for patients, nightmare for us, is the patients who have intractable pain. There are some people you control the RPF, but the nerves remain incredibly painful, strangulated, and it's just a shocker. We move them into chronic pain services for interventional pain management, etc., etc., etc. People who've had all sorts of pain, the implants in the spine or blocks, but I think if you're managing an RPF service, having a pain specialist who is all over the handful of patients who have intractable problems with pain is really good.
Is that a significant proportion of patients, Tim?
Yeah, I think it probably is, maybe 10%.
Oh, wow.
Yeah, no, I mean, a lot of people's pain in RPF is quite tricky. Some of it's due to the obstructed ureter, so some of it gets better once you've done that. Some of it's because you've got the inflammatory tissue and it's pressing on nerves and there's inflammation and, it goes with the steroids. But some isn't. You just have cold, fibrotic, nasty tissue strangling nerves. And it's a shocker.
Well, that's an absolutely fascinating and hugely relevant point to end on there, I think.
Yeah, no, I mean,
Tim, and can I just thank you again for joining us on a Tuesday evening and sharing your expertise. I think that's been a hugely illuminating discussion, Sophia.
Yeah, I think we're going to look very clever when we request our serum lines, Harry.